Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, everybody, and thank you for joining this lecture today on precision imaging and cardiac MRI using late gadolinium-enhanced imaging. My name is James Carr, and I'm a radiologist and professor at Northwestern University Feinberg School of Medicine in Chicago, Illinois, in the United States. In today's talk, I'm going to cover four distinct areas. First of all, I will give an overview of cardiac MRI techniques, and then I'll go into a little bit more detail on the techniques used for late gadolinium enhancement. I will try to illustrate some of these techniques with clinical examples, and finally, I'm going to finish up with a few artifacts that we encounter and how we try to deal with those. So first of all, let's talk about the CMR techniques. So the beauty of MR is that you can run multiple MRI techniques in the same protocol, and these are all illustrated here. We can do dark blood imaging for looking at anatomy. We can do cine imaging for looking at function. We can inject contrast and image perfusion in the heart. We can look for scar in the heart. And then anytime we inject contrast, we can also look at the blood vessels with angiography. So even though the cardiac MRI protocol may seem complex, in fact, it is very straightforward, and it's illustrated here. The basic cardiac MR protocol consists of a combination of cine images, as shown on the top. Once we've completed the cine images, we typically will inject gadolinium contrast anywhere from a single dose to a double dose, wait about 10 to 15 minutes, and following that, we image the heart post-contrast in the delayed phase to look for any enhancement within the myocardium as shown here on the bottom set of images. So this protocol of cine imaging, inject the contrast, plus delayed enhanced imaging is the basic CMR protocol and addresses most of the indications that you encounter with cardiac MRI. There are, however, many newer techniques which can be integrated into the basic protocol, and they are shown here. We do have a more rapid cine imaging technique available using compressed sensing, just a term used for accelerated cine MRI of the heart, and I'll show you how that's integrated into clinical practice. We can look at regional function using tissue phase mapping, or various techniques for looking at function at the segmental level. We can do mapping techniques to look at scar or edema at the microcellular level, and all of these are typically combined together to really enhance characterization disease when you're running your CMR protocol. Now, there are many indications for cardiac MRI. In this talk, we're going to primarily focus on ischemic heart disease, but these are all the other indications are listed here, and it really covers the full spectrum of cardiovascular disease. So this is not really so much a niche test anymore. It's really much more of a mainstream test for assessing cardiac disease. So let's delve into some of the techniques for late gadolinium enhancement. So when you look at the standard CMR protocol in the schematic here, it illustrates the sequence of techniques that we use. So we typically start with a series of scouts. We do cine imaging in a number of different orientations. We inject the contrast, and then we do delayed enhanced imaging. And there are a number of different techniques we can use for delayed enhanced imaging. You can either use these techniques together or use one over the other. You can integrate other techniques anywhere along the workflow of this protocol, such as mapping or 2D or 4D flow can occur at any time point. And also to save time with our standard protocol, we typically inject the contrast early, usually before the cine imaging, or some places will actually inject the contrast right at the beginning of the study to really save time. So when we're evaluating ischemic heart disease, we typically focus on these three basic techniques. Now, coronary MR angiography was very popular as a technique for evaluating ischemic heart disease, but has essentially been superseded by CTA. So I'm not going to focus on that as much. The other two techniques, stress perfusion imaging to look for any ischemia in the heart, is a very useful technique, as well as delayed enhanced imaging, which we're going to focus on in this lecture. So, with the standard protocol, we run a stack of conventional cine images of the heart, and we cover the heart from the base to the apex with short axis images as shown here. And we always carry out three what are termed long axis views, and they're shown here: a four chamber, a two chamber, and a three chamber view. These are the various parameters that are used. So we're aiming for 50 millisecond temporal resolution, which is the frame time. We always use parallel imaging, and we try to aim to be able to acquire 1 to 2 slices per breath hold for complete cardiac coverage. So if you just consider with a cine acquisition, it may take 10 to 15 minutes to cover the entire heart with standard cine imaging approaches. Now, not all the time do standard cine images work, and this is particularly in the case of patients who cannot hold their breath or patients who have an arrhythmia. And if that occurs, you end up with a significant reduction in image quality, and you have to uh, pivot in that point to real-time cine MRI, as shown here. This is the patient from the ICU. You can see the pleural effusions, so the patient can't hold their breath. We ran real-time cine imaging, so you can see the images are less sharp, but it still gives you a pretty good idea of function at a frame time of 65 milliseconds. And this is carried out free breathing without any ECG triggering. We can speed up this acquisition now significantly with this compressed sensing approach. This allows you to essentially denoise the real-time acquisition. As you can see in this other set of images, these are real-time cine images of the heart with much sharper and much better image quality. These are carried out free breathing now with a frame time of approximately 50 milliseconds, which is comparable to the approach that we take with standard cine segmented imaging. As I mentioned earlier on, we also try to speed up the protocol by injecting the contrast early. And there's have a number of studies being performed. This is one where they compared cine images with contrast administered and without contrast administered. And you can see that if you administer the contrast early, even though the myocardium looks a bit brighter, it has no impact really on the quantification of the ventricular parameters, such as ejection fraction, end diastolic volume, end systolic volume, and stroke volume. So really, injecting contrast is a very useful way of speeding up the overall protocol. So let's look at what the late gadolinium-enhanced imaging looks like in conjunction with cine imaging of the heart. So on the left, we have our standard delayed enhanced acquisition, here showing a thinned myocardium in the anterolateral and infralateral wall of the heart. The arrow is pointing to that area of thinning, and you can see there's some enhancement here. And then we look at the cine image on the right, you can see that that area is also markedly thinned out and akinetic. There's also an associated pericardial effusion. So this is an example of a patient with a transmural infarct in the lateral wall with an associated wall motion abnormality also affecting that area. And it's very important, to illustrate that we look at the cine imaging and the late GAD and enhanced imaging side by side, so we get a good correlation between the function and the amount of scar within the heart. So how does late gadolinium enhancement work? So if you consider that we inject the contrast, as I mentioned, you try to inject the contrast at the beginning of the protocol to speed up the overall protocol. When we inject the contrast, in normal myocardium, the contrast washes in and washes out. With ischemic myocardium, the contrast washes in and washes out, but you just got less uptake in this area of ischemia. And then for delayed enhancement, what happens is the contrast, when it is injected and when it encounters an area of scarring, there is a breakdown in the blood tissue barrier. The gadolinium contrast is retained. Gadolinium is a T1 shortening agent. And when you image the heart with a T1 weighted technique, which is what our delayed enhanced imaging technique is, you get bright signal. And this is shown here by the bright signal retained in an area of subendocardial infarction in the inferior and infralateral wall of the heart. So the essence of delayed enhancement is around being able to image the heart where you get gadolinium retained in abnormal fibrotic tissue, but also at a time point where it's accumulated in enough of a quantity to allow you to image that area of abnormality with high signal. So here's another comparison of late gadolinium enhancement imaging. We've got a single shot inversion recovery technique on the left and a segmented acquisition on the right. And you can see with the single shot technique, you get rapid coverage of the entire heart with pretty high image quality. Whereas when you look at the segmented acquisition on the right, we're only getting one slice at a time. And this is because each slice has to occur with a single breath hold. Interestingly, with the segmented approach, we also, for free, get a magnitude image as shown on the top and a phase image as shown on the bottom. And you can see the difference in the image quality between the two techniques, whereas the magnitude image, in this case, the thrombus is showing in this area of a pseudoaneurysm shows bright, whereas the thrombus within the pseudoaneurysm is dark, confirming that it is, in fact, a thrombus which is present. So what are the recommendations that I would make for late gadolinium enhancement imaging? You use an inversion recovery technique, and the examples I'm showing are inversion recovery turboflash or inversion recovery SSFP, and I'll show how these are used in practice. We typically inject anywhere from a single dose to a double dose of gadolinium contrast. A single dose of contrast is in fact adequate. You image at 10 to 30 minutes post-injection. If you inject a single dose of contrast, you tend to image earlier at about 10 minutes, whereas if you inject a double dose, you're going to image at about 15 minutes. And late gadolinium enhancement visualization depends on the technique used, the dose, and the image acquisition delay post-contrast injection. Now, a number of studies have been done on dosing of contrast for cardiac MRI, and one of these is comparing a single dose contrast agent as a high relaxivity agent to a standard agent, which was a double dose. You can see that there was really no differences in visualization of the myocardium, quantification of parameters between the two techniques, as well as signal to noise and contrast to noise. As mentioned, however, if you do use a single dose of contrast, it is recommended that you image a little bit earlier at 10 minutes compared to if you use a double dose of contrast, you'll image a little bit later at 15 to 20 minutes. So you need to bear that in mind as you structure your protocol. So how does inversion recovery imaging actually work? Well, first of all, the shorter T1 of the contrast-enhanced infarcted region results in a faster signal recovery following the inversion, and nulling of the signal from the longer T1 viable myocardium results in a maximum contrast ratio. So what you're aiming to see is maximum contrast between the normal dark myocardium and the enhanced infarcted myocardium. So how does this work in practice? Well, when you start running your technique and you run your inversion pulse, it flips the magnetization 180 degrees into a completely inverted state. And then the various tissues in the myocardium begin to recover in accordance with their T1 relaxation times. Normal myocardium will occur at this rate, whereas myocardium which has a short T1, i.e., which contains gadolinium or fat, for example, will recover more quickly. So if you image at a time point called the inversion time, whereby the normal myocardial signal is completely nulled, you get minimal signal from the normal myocardium, but maximum signal from the short T1 myocardium, which is the myocardium containing the contrast. And that's how we do inversion recovery delayed enhanced imaging. Now, one of the challenges with delayed enhanced imaging is trying to determine what that actual inversion time is. And one of the techniques we can use is what's called a TI scout, where we image the heart across multiple inversion times, and then we select the exact inversion time based on the Cine loop where the myocardium is completely nulled. And this allows us to plug that inversion time into the sequence parameters at the user interface on the scanner. So if you look here on this set of images, and these are the normal magnitude images on the left, you can see that an inversion time of 250 milliseconds, results in complete nulling of the myocardium. So if we selected that from the TI scan, we would get an image that looks like this. If you imaged earlier than that, you will get an image where the myocardium is inadequately null, so bright. Or if we image too late, you get a low contrast image of the myocardium. Now, thankfully, we have an improvement on this version, which is called phase sensitive inversion recovery imaging, where we can also reconstruct the images with a phase sensitive reconstruction algorithm that allows us to always null the myocardium. So you can see here, even in this set of images, which is the same acquisition, when the TI is too low, with the PSIR images, you always get nulling of signal from the normal myocardium. And this greatly simplifies the acquisition with delayed enhanced imaging. Here's an example where we have some scar. So for example, you can see on the bottom here with the magnitude image, you can see the scar here where you have an optimal TI, but when you have a suboptimal TI with the magnitude image, you cannot see the scar. Whereas with the phase sensitive reconstruction, you always see the scar, even when the TI is too short or even when it is too long. So it works over a wide range of inversion times. Another variation on the technique is the comparison of a segmented acquisition versus single shot acquisition. So with a segmented acquisition, only part of the image is acquired in each heartbeat, and you need multiple heartbeats to build up the image. Whereas with a single shot acquisition, the entire image is acquired in one heartbeat. So you can imagine with the segmented acquisition, we're using multiple heartbeats. If the patient moves, if there's an arrhythmia, we have a problem, and it results in a significant reduction in image quality. So this is what the single shot acquisition looks like. We acquire multiple images. The entire image is acquired in one heartbeat, but it allows us to image the entire heart in a single acquisition. It can be carried out free breathing. It is insensitive to arrhythmia. It does allow you to cover the entire heart. However, it is generally lower in resolution because you're acquiring the images far more rapidly. We now see an improvement on this technique. This is a newer version where you can do a free breathing motion corrected single shot imaging technique. Again, still using the single shot approach, but then by averaging several images together, you maintain the signal in the image and it allows you to maintain higher spatial resolution. And this technique now brings us to a point where we're actually able to approximate the quality of a standard segmented acquisition. So here's the raw image on the left, looks like your standard single shot approach, whereas the motion corrected averaged image on the right looks like a standard segmented approach. But bear in mind, this was carried out during free breathing. So this allows us to potentially replace our standard approach with the more rapid approaches. We also have a 3D viability imaging technique, as shown here, where you can cover the entire heart with 3D. Takes longer to acquire these images. The image quality may not be as good. This may be useful, for example, if you're really looking for small amounts of thrombus in the heart or looking at the left atrial appendage, for example. So this brings us to the rapid CMR protocol. We now have techniques such as the rapid real-time cine imaging technique with compressed sensing, as well as the single shot motion corrected approach to really perform a simple cardiac MR protocol in less than 30 minutes, and in many respects, less than 10 to 15 minutes. Again, with these, you can inject the contrast early, right at the beginning of the acquisition to save time. You can add in some of these mapping approaches if you want to better characterize disease, but it really allows you to image the heart with a standard protocol in a very short period of time without any complexity associated with it. You can even add on stress perfusion to that rapid CMR protocol. Again, looking to convert a complex stress perfusion protocol to a simple rapid protocol in less than 20 to 30 minutes. And this particular approach has been published in the literature fairly recently. Okay, let's talk about some clinical examples on what they look like with cardiac MR, particularly as it relates to ischemic heart disease. So first of all, let's look at the enhancement pattern post-gadolinium. Gadolinium agents are non-specific, but we can divide it into ischemic patterns of enhancement and non-ischemic patterns of enhancement. Ischemic patterns of enhancement are typically subendocardial or transmural, whereas non-ischemic patterns of enhancement tend to be intramyocardial, so mid-myocardial or subepicardial. That's the broad distinction between these two entities. So this is a pretty standard myocardial infarction. You see a very dilated left ventricle with an akinetic and thinned anterior wall and transmural enhancement of this area of abnormality. This is a transmural enhanced myocardial infarction. Compare this with a subendocardial myocardial infarction as shown here. You see this subendocardial enhancement in the septum, which does not reach 50% of the myocardium, which is an important distinction to note, as illustrated from a study now over 20 years old, which showed that patients who were undergoing bypass surgery who went cardiac MRI, if they had enhancement occupying less than 50% of the wall thickness, they were much more likely to recover their wall motion post revascularization compared to if it's over 50% of the wall thickness. So 50% transmural extent of enhancement is the golden key figure that has to be used to determine whether something is viable versus non-viable. You can also quantify the amount of scar in the myocardium as shown here. If you have scar that is over 45% in this study of the overall myocardium, it's a far worse prognosis compared to if you have scar occupying less than 15% of the overall myocardium. Here's another example of an enhancement pattern called a no reflow zone that occurs in acute MI. You see this area of enhancement of the long axis view, which is very dark center centrally, which is the no reflow zone, consistent with microvascular obstruction. This indicates that the infarct is so acute that the gadolinium doesn't get into the central area. If you were to image this over time, this would eventually fill in. It would also show elevated T2 on T2 weighted imaging, and it's also associated with a worse prognosis. The absence of enhancement is also important. This is an example of a patient with an acute chest pain and stunned myocardium. This is known as Takotsubo cardiomyopathy or stress-induced cardiomyopathy, where you essentially get stunning of the myocardium. You can see the wall motion abnormality at the left ventricular apex, but no evidence of enhancement. So this is a good prognosis for this patient. Any intramyocardial masses are also of concern, particularly in the setting of infarction. So here's a patient with extensive enhancement in the septum and also at the apex of the heart. There's this area of mass towards the apex, also seen on the cine image, which is consistent with the presence of intracardiac thrombus. Unlikely to be an actual neoplasm just in that area. You'll see the bright signal within the thrombus at the apex. You can also image the heart here with a longer TI, so-called long TI imaging, to try and null that thrombus at the left ventricular apex to try and confirm that this is in fact thrombus. We can also see aneurysms post-infarction. This is a patient with a true aneurysm coming off the inferior wall of the heart. We see this transmural enhancement in that area, as well as in the anterior wall. True aneurysms are characterized by a wide neck. You see this wide neck as it originates from the inferior wall of the heart. If you compare this with this particular aneurysm or pseudoaneurysm, which is a narrow neck arising from the lateral wall, again, this is characteristic of a pseudoaneurysm. Frequently, these contain thrombus. I showed the example of this already, where you've got a magnitude image which shows bright signal from the thrombus. You'll notice on the phase reconstructed image that the signal from the thrombus is completely nulled out, confirming, in fact, that this is thrombus on the phase image. Here's an example of a clinical case. This is a stress perfusion, cardiac MRI, patient who came in with a bypass 8 years earlier, coming in with new onset chest pain with an elevated troponin. This showed a defect in the anterior wall of the heart. We did other imaging sequences as we normally do as part of a CMR protocol, and you can see the late enhanced images on the bottom showing enhancement in this inferior wall, enhancement in the anterolateral wall. You can see an area of low signal in this area of enhancement in the anterolateral wall, suggestive of a no reflow zone. We went on to do T2 weighted imaging. These are edema weighted images up on the bottom here, which show elevated signal in that anterolateral wall, confirming that this is likely an area of microvascular obstruction or no reflow zone, and suggesting that this is an area of acute infarction in the anterolateral wall, whereas the area in the inferior wall is likely chronic infarction. So it turned out that there was a chronic MI inferior wall as shown on MRI, but also an acute anterolateral wall infarct with edema and no reflow zone. This had been missed on a cardiac catheterization, but on review of the cardiac catheterization revealed that there was an occluded small obtuse marginal branch. So again, illustrates the importance of MR and how this can really be used to characterize disease. Now, how does mapping fit into our cardiac MR protocol? Well, we've seen mapping used in a multitude of other conditions, such as amyloidosis in particular, but it also shows elevated T1s and elevated ECVs in conditions with chronic infarction as well. So it may be useful in that setting. And there have been a number of studies performed. Here's a patient with a known inferior wall infarct, and you can see when you look at the native T1, there is elevated T1 in the native pre-contrast T1 mapping technique. So it suggests that perhaps native T1 mapping can be used to detect infarction within the heart. And this is shown in this study where it showed elevated T1s in patients that had both viable infarct as well as non-viable infarcts. We can also use mapping to help us distinguish between acute MIs versus non-acute MIs. Here's a patient with an acute MI on the classic no reflow zone with a dark signal in the lateral wall area of enhancement. There's elevated T2 here in this area indicating edema with low signal century suggesting necrosis. We can do T1 mapping, which shows elevated T1, T2 mapping, elevated T2, also helping us to characterize disease. And then another elegant study here shows how all of the mapping techniques can be put together, T2 mapping, late gadolinium enhancement, as well as T1 and ECV, to help characterize and distinguish patients with acute infarction, chronic infarction, as well as suspected acute coronary syndrome. The most useful in actual practice is T2 mapping to be able to distinguish edema versus non-edema. The edema is a marker of acuity, so acute infarctions will show elevated T2. Acute myocarditis, for example, will also show elevated T2. Let's now finish off with some artifacts. So a common artifact we may see, particularly at 3T, is this so-called disruption artifact across the SSFP image. You see this dark line extending across the image. In this instance, you typically have to manually change the frequency of the cine acquisition to be able to get rid of this dark rim artifact on the image. And you can go in and manually measure the frequency shift and then plug that into your user acquisition. So this is one type of artifact which is more common at 3T. Another artifact which we alluded to already is the segmented cine acquisition that's shown here on the left, where you have a lot of motion precluding accurate assessment of disease or wall motion. In this instance, you do need to revert to real-time cine imaging. So switch from the segmented approach to the real-time approach and see that with the real-time imaging, the image quality is not as good, but at least it allows you to be able to determine whether the heart is functioning to any great degree or not. Patients who cannot hold their breath, for example, is shown on the left. The segmented approach really doesn't work in patients who can't hold their breath. So you really do have to run a single shot IRSSFP approach. You can see this is the same patient, same image. The single shot image really shows this infarction much better compared to the segmented approach, which has failed in this instance. Incomplete nulling of the myocardium I showed you already. As shown on the left here, you see the bright signal in the magnitude image on the left. The phase-sensitive images, which are reconstructed from the same algorithm, show adequate and complete nulling of the normal myocardium. And then finally, for patients with devices, we cannot use the standard techniques because we get all of this artifact over the myocardium. You need to revert to this so-called wideband late gadolinium enhancement technique, and you can see that it significantly improves the artifact both in perfusion images as well as on late gadolinium enhancement imaging. So just to finish up, what are the key points? Well, the basic CMR protocol is very simple if you use cine imaging and late gadolinium enhancement imaging, and can be used to assess most cardiovascular conditions. Contrast enhanced MR can be carried out at lower doses of 0.1 to 0.15 millimoles per kilogram. Late gadolinium enhanced techniques are now simple and easy to implement, and most artifacts with CMR can be corrected with simple measures. So thank you for your attention.